So I'm going to continue now with a transition from cognitive psychology into cognitive therapy itself. I was talking last time about how it is that when we look at things, we actually don't see them as they are, we see them as we are, as Anais Nin says. In cognitive psychology, we know that the mind has to process things according to our perceptions. That perception interfaces with our memory. Then that interfaces with the way in which what category we put it in. We categorize it. We need to be able to identify it with words and associate it with other experiences that we have. And then that allows us to make judgments. So our perception, memory, categorization, and judgment all contain different components. We could go into this and it would be an entire course. So I don't want to do an entire course on this. So I want to just talk a little bit about what's called selective apperception. Selective apperception means that we are bombarded by tens of thousands of pieces of data every second, both from the outside and from the inside. Our emotions, our feelings, what's going on in our personal lives. And those things distract us from paying attention to certain outside things. And sometimes the outside things distract us from what's going on the inside. So what we end up focusing on and paying attention to, we select this. This is in a sense, our choice, where we select out what it is that we want to pay attention to, and this is called selective apperception. We select what it is that we're going to pay attention to. Sometimes consciously, sometimes it's demanded. A loud sound comes and our attention goes to that. Learning about cognitive therapy is learning how it is that we end up paying attention to things, or how we automatically respond with certain thoughts and feelings at different levels. So I want to talk about 3 levels of how it is that our thinking takes place from the point of view of cognitive therapy. We have what are called automatic thoughts, conditional beliefs, and core beliefs. Automatic thoughts are on the outside of our interfacing with the world. Conditional beliefs are what-if statements that are a little bit internalized. And then core beliefs are right at the center, where we generalize from our experience into the specifics. Let me go into more detail. Automatic thoughts are a class of mental reactions in words or images to a specific situation, either real, imaginary, or anticipatory. Automatic thoughts usually take the form of a short, spontaneous reaction, a longer internal monologue, or a mental image, experienced sometimes like it were a short movie. So when we experience something, we start having thoughts about it. That's this automatic experience that we have. Let's take the example of a dialysis patient, because dialysis patients are more prone to possibly be at risk for depression. So we say that the automatic thoughts takes this form of a reaction. I hate having to go to dialysis every other day. Not only do I have to go to the clinic 3 times a week, I have to watch my fluid intake. It never ends. And then I imagine myself dying and in pain no matter how good my compliance has been. Conditional beliefs or intermediate beliefs are more general than the automatic thoughts. but more specific than core beliefs. Often conditional beliefs are found to take the form of if-then statements. In this way, the statements are conditional rather than universal in application. Conditional beliefs are a class of beliefs about specific situations set against a more general background. Assumptions. If I watch my fluids and can get regular with my treatment, then I can get on the transplant list. That's a good example of an if-then statement. I want to please the nurses and social workers and doctors. I want them to be happy with me, so I'm going to do my best. I'm going to remain hopeful, even if I have some rough weeks. And when a person does their best with their treatment, they should be able to get on the transplant list. So these are some more positive conditional beliefs that might offset some of the negative automatic thoughts in our previous example. Now let's take a look at core beliefs. I've said core schematic beliefs. Schemas are a little bit more subtle, but I don't want to go into such detail at this point. We can say core beliefs are found in childhood and are influenced by parental models. These early core beliefs form the basis for general coping strategies for dealing with major life issues. Most core beliefs are global statements covering a multitude of situations. Early modeling, my father had diabetes and kidney failure, and he was pretty hopeless. I want to keep up my hope no matter what. People are foolish when they don't take care of themselves, when they don't appreciate their good health. The world is not always fair, but at least there's a treatment for this problem that I have. So here is a mixture of positive and negative thoughts that people have in the core beliefs. These are just some examples that I wanted you to see the difference between these different levels. So this is the culmination slide of what it is that we just talked about. So in depression, we usually can just work from the level of cognitive thoughts, automatic thoughts, and we do a treatment method that's called cognitive restructuring. We'll be talking more about what cognitive restructuring is in another talk. When a person has an anxiety disorder, not only do you have to work on the automatic thought level, but we need to also work on the conditional belief level. And we use imagery and exposure techniques. We also would use mindfulness training as well. When we talk about personality disorders or long-standing depression, sometimes we also have to look at our core beliefs as well, along with the conditional beliefs and the automatic thoughts, and we need to do what's called schema change. This is a much longer, protracted treatment, but also very effective and helpful. So you can see that depending on the diagnosis that the person has, the symptoms that they have, there's a treatment method for each one of those. As I had said before, when we do cognitive behavioral therapy, we have different treatment protocols for the different disorders. We don't treat depression the same way that we treat anxiety. And even within anxiety, we have different treatment protocols for phobias and for panic disorder, OCD, and post-traumatic stress disorder. We have different treatments. They vary. And then we customize those for each person depending on their individual circumstances. So when we use the term cognitive restructuring, what do we mean? We mean that there's a step-by-step process that we use. We observe the thoughts and their thinking patterns. We identify whether the thoughts are significantly negative. Sometimes we use a list of what's called cognitive distortions. We can talk about that a little bit later. We use a conceptualization model to map out the thinking pattern, as we had done in our previous example of the circle with the 5 different parts of our problem. And then we use a thought record to examine the evidence and to construct an alternative thought. And then finally we do behavioral experiments to test out whether this new thought is effective. As a new balanced thought, we can adopt it or not. It's our choice to do that. So this is a little bit about how cognitive restructuring works and how we can work together to see, as a therapist and a patient, collaboratively, we work together to try to solve some of these difficulties that we have. I hope that this information is helpful to you and that we can proceed further into our next study of how we can use CBT together. Thank you very much.